accepting the invite, Dr. Urvi, and over to you.
Sharing.
Okay.
Give me a minute, I've just lost that screen somewhere.
Now, I sincerely request all the participants to mute themselves, please.
देखो ना
Right.
छोटी वाली का दे फटाफट
Okay, can you see this now?
Yes, we can.
Dr. Deva, for a very kind introduction. The topic for today is thrombolysis for intraventricular hemorrhage, and we are going to be discussing we are going to be reviewing some evidence that we have. Okay, so right. So I'll start with a case. This is an actual patient in our ICU. He's a 42-year-old hypertensive male. He stopped his antihypertensive medication 6 months ago, came to our hospital with dizziness, frothing at mouth, inability to move the left side of his body for last 5 hours. Stroke code was announced. On arrival, his GCS was 11/15, and an urgent CT scan of the brain was done. And this is the film of this is the picture of the scan. It shows a left thalamocapsular bleed with intraventricular extension. There is some amount of pressure effect. The right side ventricle looks dilated, and there was a midline shift of nearly 3 to 4 millimeters. So this is how he presented to us. Now, talking about some statistics before I go on to to presenting the evidence that exists for intraventricular thrombolysis. There is in India the incidence of intracerebral. In India, the incidence of intracerebral hemorrhage is around 10 to 15% of all the strokes that present to hospital. Mortality is reported at 40%. 1/3 of these patients have an intraventricular extension, and obviously, when there is intraventricular extension, the mortality increases slightly, and it is reported anywhere between 50 to 80%. Outcomes, when we use modified Rankin score, so outcomes of more MRS score of more than 4 is actually 3 times higher with intraventricular hemorrhages. So these patients actually do very poorly considering the neurological function at 3 months and 6 months. So this is how bad the intraventricular extension of intracerebral bleeds can get. And a little bit about the pathophysiology. We all know that presence of blood in the neurological tissue initiates a kind of inflammatory response, which causes a lot of vasogenic and edema, and also an edema because of compression of the surrounding neurological tissue. External ventricular drain seems to be most effective in controlling this ICP and reducing mortality. But however, these drains sometimes need to be kept for very long, and we all of us know the problems or the drawbacks of keeping EBD catheters for a very long time. Mostly it is the infection, and secondly it is the ventriculitis because of a mechanical device which sits into the ventricle. And this was the theory that maybe if we used adjuvant thrombolysis, it may help to clear the clot faster and reduce the toxicity of the hemoglobin breakdown products. So the research actually began in early 1990s, and there were a few studies that were published. They were really case cohort studies, and some retrospective or prospective observational studies with small numbers that were presented or that were published, which explored this concept of intraventricular hemolysis. So today's evidence, we would like to discuss this considering, talking about four questions. So first question, the fundamental question is, should we even be thinking of thrombolizing patients with intraventricular hemorrhages? If we want to thrombolize, then what drug and dose should we be using? Are there complications of using these drugs and the procedure of intraventricular thrombolysis? What is the general evidence on how people are doing this thrombolysis? And finally, I would like to summarize this with a very nice meta-analysis, which we will see subsequently. So initially, like I talked about, the research on intraventricular thrombolysis began pretty early in the 1990s. And this was the first meta-analysis that was published over a period of 10 years. The data gathering was over a period of 10 years from 2002 to 2011. This was published in 2014 in Stroke Journal. And they looked at intracerebral hemorrhage. So the diagnosis of intracerebral hemorrhage in roughly around 6,55,000 patients, out of which 6,12,000 patients never had any ventriculostomy or never had an EVD placed. 42,000 patients had an EVD placed, out of which 34,000 got included, and only 1,333 patients actually had an intraventricular thrombolysis done. And 32,000, roughly 33,000 odd patients did not have any intraventricular thrombolysis that was done. If you look at the inpatient mortality, there was a very significant difference, 41 versus the 32% in patients who got thrombolysis. However, patients who had an unfavorable discharge or patients who were neurologically very poor at outcomes, at discharges, remained non-significant. So basically, probably we were saving patients' lives, but we were not actually giving them better quality of life. However, there were few very important indicators. There was an increase, the trend to use in external ventricular drains or EVDs had increased from 5.7% in 2002 to roughly around 7% in 2010-2011. And the rate of intraventricular thrombolysis had also increased from 0.6% to 5.6%. So this was a good start. Then came the CLEAR 3 trial. Till today, it stands the largest randomized controlled trial of intraventricular thrombolysis in patients who have intracerebral bleeds with intraventricular extension. So this remains the largest trial. It was done in over 500 patients, 245 randomized to each arm. They used alteplase to thrombolize patients with intraventricular extension, and the other half were only treated medically, probably just aspiration of blood clot from the EVDs. So all the 500 patients had an EVD placed, but only half of them had intraventricular thrombolysis or alteplase instilled within the ventricular space. What they saw was a very clear mortality benefit. It was roughly, it was a significant mortality benefit. However, if you look at the screen on the right-hand side, the gray, blue, yellow tells you the MRS score up to 3, which indicates that these patients had better functional outcomes at 30 days and at 180 days. They used both the Rankin score and the Glasgow outcome score. And what they realized was that though the red bars stand for mortality difference, though there was a significant difference in the mortality, or definitely more patients were living, there was not much difference in good functional outcomes. So the problem was we were probably allowing more patients to live, but they were not having good functional outcomes. So there was this critique that probably we were producing more vegetative state patients. And in India, we can understand that if we have such patients, social, ethical, and moral responsibility lies with us because we don't have very well established palliation and long-term home care support. However, few things that I would like to mention about CLEAR 3 trials. This is probably the only trial where they had defined the end of treatment outcome. So they had defined at what time alteplase injections would be stopped. And they said that there should be clearance of the third and the fourth ventricle. At least 80% of the clot needs to clear. And this was studied obviously with a repeated CT scan. So in their protocol, they were doing a CT scan almost daily to find out how far the clot clearance was achieved. And the average or the median duration of use of alteplase in this study was 2.5 days versus the control arm where they were aspirating clot or they had connected the EVD to a drain bag for roughly around 5 to 5.7 days. So there was definite difference. The clot resolution was much quicker in the alteplase group as compared to the control arm. Only 21% of the total 500 subjects that were enrolled in this study had achieved their target of 80% clot clearance. And in the alteplase group, it was only 10% who could achieve that clearance of 80% of the clot resolution. So this was another critique of this trial. But again, categorically proved that there was definite mortality benefit, and this is still remains the largest randomized controlled trial. We also had another systematic review that was published in 2024. All this time, there basically people were using two drugs. One was alteplase and the other was urokinase. And so far, we had only a few studies which actually had randomized controlled trial. Now, this was a systemic review and a meta-analysis which only involved RCTs. They did not include the cohort studies, the prospective or the retrospective observational studies. So they found four randomized controlled trials, RCTs, which they included in their meta-analysis. Hanley et al. is where you can see 240 in the RTPA group and 245 in the placebo group. That is the study, that is the CLEAR 3 trial. And there were two studies which used urokinase. UK stands for urokinase. You can see that the overall enrollment, there was just 12 patients in one trial and 16 patients in the other trial.
Okay.
However, they did show mortality benefit in all the four trials, irrespective of whether it was urokinase or alteplase. So this was something to be kept in mind. And, there was a significant mortality reduction. Overall, the risk reduction in the subset of alteplase group, the odds ratio was 0.54. And in the subset of urokinase group, it was lower than the alteplase group, and it stood at 0.21. And they confirmed that the heterogeneity in all these four randomized controlled trials was actually very low. So I went back to find out if there were more RCTs on urokinase. But apart from the two RCTs that were included in the previous meta-analysis, I couldn't see anybody else. I couldn't see any other studies. This was a cohort study, but this is the largest urokinase study that has been published, and it included roughly around 44 patients. And it was a cohort study of a 4-year experience with ventriculostomy and treatment of IVH with or without adjunctive intraventricular urokinase administration. Again, if you look at the in-hospital deaths, there is a significant benefit of using adjunctive urokinase along with ventriculostomy. However, there was no major difference in the incidence of vegetative state in all the patients that were enrolled in this trial. So I think for the first question, I think there is definite mortality benefit, but we don't see any functional benefit, or there is no benefit in neurological or the quality of life or neurological outcomes. Okay, so we come to the second question, what drug and dose? I would like to confess here that I have used Perplexity to help me find the varying doses that have been included in various trials. And this is the alteplase dosing that I found. So it ranges anywhere from 1 milligram every 8 hourly, which was used in Clear 3 trial, to even 4 milligram 12 hourly with a max total dose of 20 milligrams. So you can see that the dose has varied considerably over the period, over multiple trials that have been published. And therefore, that leaves us with really no concrete base on if we decide to use intraventricular thrombolysis in our unit. It doesn't leave us with any confidence about what dose to use. But the maximum or the most commonly used dose was 3 milligrams to be given every 12 hourly. The same with urokinase. The urokinase dose in different studies varied from 5,000 units to almost 80,000 units, which was given once daily. And this high dose group, they actually, their endpoints were very different. It was not mortality, but it was whether there was presence of rebleeding or whether there was presence of increased incidence of ventriculitis when they used such high doses. So we will be talking about the incidence of complications when we use such high doses, but again, very variable dosing regimen, and therefore does not give us any confirmation of what is the most beneficial dose that can be used in any of the studies. Complications of the use of fibrinolytic, yes. So this is a study there where 60 patients were enrolled and randomized to alteplase to receive alteplase 2 milligrams 12 hourly for 4 days versus saline. Here there was no end of therapy. They didn't have any end of therapy defined. However, they limited the treatment to only 4 days. There was a significant reduction in hematoma volume at 4 days, better GCS score, and they found it to be safe. There was no difference in bleeding, hematoma expansion, or meningitis. And again, if you see, the outcome score at 1 month was similar in both the groups. However, they were not sure if the dose that they had used was optimal because the numbers that were enrolled in the study were only 60 patients, and therefore they concluded that this study was then open to further research. Another trial which enrolled 48 patients, randomized to 3 milligram alteplase versus saline. Randomization was done within 24 hours of clot stabilization, and they've also looked at severity of complications, and they found that they did not find any difference in the incidence of complications between those who received alteplase versus the control arm. However, they saw that they had to use alteplase for a median duration of 7.5 days versus just clot aspiration for 12 days to get the same benefit. So again, we don't have a very clear idea on the duration of the drug that we should be using. This was the severities. This was the table that showed us the severity. If you see the GCS in both the groups, the RTPA group and the placebo group was 7 and 8. So they were severely affected patients. The ICH volume also was similar, and the intraventricular bleed volume was also similar, anywhere between 50 and 54 ml. And however, they saw that the symptomatic bleeding events in the group that received RTPA was significantly higher as compared to the placebo group. However, the mortality and the incidence of ventriculitis did not change or wasn't significantly different. So the main complications that have been reported across various studies that have been published so far from 2000 to 2024 is ventriculitis. It was 26% in one series. Incidence of rebleeding, that is 7.1%. Hydrocephalus, not precisely quantified in any of the trials. Drain obstruction, well, it actually, they showed to be reduced with fibrinolytic use. Infection, similar to when they used EVD alone without fibrinolysis. And other rare events were not, there were no significant increase in any other serious events in the reviewed studies. So these were the references that I used to find out the incidence of complications in the studies published in the last 2 decades. So finally, if I put everything together, so a rough estimate of how we can do intraventricular thrombolysis is obviously you will need EVD catheters. Most of the studies have reported that they locked the catheter for 1 to 3 hours after installation. The volumes of drug that were instilled were very low, again 1 ml to 3 ml in volume, followed by a flush of 3 to 5 ml. These patients were also monitored for changes in ICP and CPP during the installation and during locking of the catheter period for that 1 hour or 2 hours or 3 hours, as the case may be. And post insertion, they definitely did CT. Insertion, they did CT and if the clot size was stable, they could initiate treatment with
just a request from all to mute themselves, please. We are listening to Dr. Urvi today, please.
Can I go ahead?
Yes, we will mute it from here also. Please continue. Thank you so much.
Okay. So post insertion, most of these trials that were that have been included in the review did a CT following insertion of EVD to make sure that there were no bleed along the track of the EVD, and also they followed it up at 24 hours to see or to confirm that the clot size was stable before thrombolytic or fibrinolytic treatment was started. And finally, the outcomes. So this is a very large meta-analysis that was published in Neurocritical Care in 2019. It was to assess the impact of intraventricular fibrinolysis after non-traumatic intraventricular hemorrhage on, and these were the indicators on mortality, functional outcome, intracranial bleed, in ventriculitis, time until clearance of the third and the fourth ventricle, obstruction of the EVD catheters, and shunt dependency. 19 studies published were included in this meta-analysis, totaling to 1,020 patients. They selected randomized control trials, prospective cohort studies, and due to the scarcity of studies, also included retrospective and matched case control series. 8 studies were classified as RCTs, 6 as retrospective cohort studies, and 5 as matched case control studies. And when they looked at the mortality, you can see that the overall mortality difference was definitely higher, definitely lower for patients who were categorized to receive intraventricular fibrinolysis along with external ventricular drains. So this was and I think they used 19 studies, all included in this assessment. For functional outcomes, the functional outcomes were assessed only in 8 studies, and this totaled 749 patients. And if you see at the overall forest plot or the overall model, there is not much difference in patients who receive intraventricular fibrinolysis plus EVD as against just the external ventricular drains. Looking at obstruction of catheters, EVD obstruction rate was evaluated in 7 studies, totaling around 185 patients, and it showed that patients who were grouped to receive intraventricular fibrinolysis actually had lower incidence of EVD blockages as compared to those who only had EVDs placed and clot aspirated. And time to IVH resolution, it was assessed in 6 studies, which totaled 596 patients. And definitely intraventricular fibrinolysis stood or gave an advantage because clot lysis or clot resolution was much quicker, anywhere between 2.5 and 5 days since the initiation of treatment of the fibrinolytic treatment. However, there were no significant difference in the incidence of bleeding. The numbers that they studied were 926 and relative risk was 1.5. No significant difference in ventriculitis rate. Relative risk was 0.68 in 15 studies. and no significant difference in the need for subsequent VP shunt. So to summarize, intraventricular fibrinolysis may be useful in large intraventricular hemorrhages with hydrocephalus. So, and most of the studies have documented intraventricular hemorrhages or hemorrhage volumes to be more than 30 ml. It definitely has a better mortality outcome, raises ethical issues with regards to increase in survival of patients who may remain in vegetative state. Largest RCT that we saw today used altiplase of 1 milligram 8 hourly, but there is a wide variation in the dosages. Evidence on urokinase comes from very small studies and case cohorts, hence cannot be commented upon. Duration of treatment varies widely, and it depends on the clearance of clot from the third and the fourth ventricle, because the change or the mortality benefit was seen only when there was an 80% clot clearance from the central ventricular space. And obviously, there is a risk of increased infection. Thank you.
Thank you very much, Dr. Urvi. It was quite crisp and clear, and you kind of dug through all the evidence that is available for thrombolysis in IVH. Thanks for summarizing the evidence, and thanks for giving us a practice summary as well towards the end. Does anyone have any questions or comments?
Deva Shalini here. If I could ask
Yes,
Dr. Urvi, what was the time at which the functional assessment has been checked in most of these studies? 6 months or 1 year?
So if you talk about Clear 3, it was 30 days, so 1 month and 6 months. There are no long-term follow-up studies as far as I remember. Most of the studies, their last long-term follow-up ended at, I think, approximately 90 days or 180 days, but nothing beyond that.
Yeah, these are so much like other neurocritical care studies where mortality benefit is there, but functional outcome is not there. Probably maybe a longer follow-up, 1 year, 1 and 2 years follow-up might show a different trend. We're not sure. Most of these studies are promising to have a little longer than 1 year when the outcome kind of turns about. So maybe it has future, not right now, but maybe.
Yeah, no, I agree completely, Dr. Shalini. But like I said, when I was going through the studies, I think it was very clear that the intraventricular volumes needed to be higher than the intracerebral volumes, and there had to be a clearance in the central ventricular space, so the third and the fourth ventricle. Probably nobody has mentioned about residual hemorrhage in the lateral ventricular spaces. So I think just the obstructive hydrocephalus, if they were able to relieve that with thrombolysis, with fibrinolysis, that is where the advantage stood. So that's the signal I got from reading through the entire thing.
Also, when has it been started? Right away at admission, or is it they've waited for a few days and then started?
No. So most studies have waited for anywhere between 24 hours to 52 hours. So the initial plan, obviously, for two, because we know now from evidence that the clot expansion takes, or the peak is at 6 hours, and after that it is less likely to expand. So most of them waited 24 hours. Then it was followed by an EVD insertion, and then they did a repeat CT and followed up with maybe a CT at 12 hours before they initiated. So unless they were sure of clot stabilization, they did not initiate fibrinolytic therapy.
Yeah, that's another area of maybe some improvement. We have some other ways of analyzing the clot stability, and this can be initiated a little earlier. It might be a change in outcome.
Yeah,
maybe.
Yeah, absolutely. True.
Thank you so much.
Thank you.
Are there any other questions or comments?
Deva, there is a question in the chat.
Which patients
Yeah.
to select for
To select for
intraventricular thrombolysis? Right. So I just mentioned, so these patients have to have, So at least all the studies that we have seen so far are non-traumatic, spontaneous intracerebral hemorrhages with an extension into IVH. So AV malformations or primary intraventricular hemorrhages have all been excluded. SAH with intraventricular extensions have been excluded from all these trials. So I think there is only one trial which included, or one meta-analysis which included intraventricular extension following an SAH into analysis or into the fibrinolysis. But the rest are all spontaneous intracerebral bleeds with intraventricular extension. The second point is the intraventricular blood volume needs to be higher than intracerebral blood volumes. The third point is, if you look at the Graves score, some studies had actually monitored the Graves score before randomizing them to giving intraventricular thrombolysis. So the Graves score had to be slightly higher in the sense that the blood in the ventricles had to create some amount of pressure effect. And fourth thing was if the blood in the ventricles created obstructive hydrocephalus. So these were the patients that were categorized or randomized then to receive either the normal or just medical management or fibrinolytic treatment. So I think you'll have to be very specific when you choose these patients for fibrinolysis. Do
Thanks,
you
Dr.
see a
Urvi.
future where minimally invasive endoscopic evacuation will replace, especially with the growing experience? Okay, so that is the Stitch 2 trial actually. So there is a trial which has done minimally invasive endoscopic evacuation of intracerebral hemorrhage, not the intraventricular blood clots. And actually, they didn't show any difference in mortality or functional outcomes, again, at 30 days and 90 days. So therefore, the evidence to use endoscopic removal of intracerebral bleeds is not very robust.
Thank you. I've got a few questions, comments. May I?
Yes, please.
Yeah. For a start, is there any Indian data, or are there any Indian studies, case series on this that you found?
No, there are some Asian
Okay.
studies, so a lot
Asian
coming
studies.
from China, Hong Kong, but not from the Indian subcontinent.
Dr. Shalini, Dr. Prashant, do chip in. At least in our center, urokinase is not available in our city. I don't know whether it's available elsewhere. So often we end up using TPA. Now, the problem we face is the TPA vial comes as 20 milligrams. So the question is, if you reconstitute, can you just keep it in the fridge? We usually keep it for 1 day and then we throw it off. But TPA being so expensive, some patients cannot afford, repeated doses. How do you manage that?
That's a good question. Actually, even I was thinking, what do I do with the rest of the TPA that would stay back? But I don't know. I haven't read about reconstituted TPA being stable for n number of days or something like that. So I would, Dr. Prashant or Dr. Shalini, anybody has any experience with this?
To me, this has given a good thought about that from the society. We should start collecting the data and get an answer from our best practice consensus from it. We shall definitely take it. Great.
I think that will be good. Dr. Shalini, you were saying something.
No, that's an excellent idea. See, your talk has created so much buzz.
Now, every time what happens is our clinical pharmacist comes and tells us that, guys, it's, the reconstituted TPA as per recommendation cannot be kept, for more than 24 hours. It has to be refrigerated between 2 and 8 degrees. If you keep it in room temperature, you have to throw it off after the first dose. You cannot use it for the second dose. In our unit, we use PD dose. We have not used TDS dose because of the logistical reasons. And it's always 2 milligrams that we've used, not 1 milligram 3 times a day. The other practical, I've written down the points questions that I wanted to ask. Yeah, so Indian data is the question that I asked. Urokinase, it's certainly not available. We used to use urokinase before because that was a cheaper option. You just, buy the vial, you can throw it off every dose, you get a new vial, but that's not the possibility now. The other question is, whenever we administer colistin, intraventricular antibiotics for ventriculitis, we always aspirate a similar amount and then administer the same amount into the ventricle, lock it and leave it for a couple of hours, and then we open it. Do you do the same with the TPA? Is that something that, or is it different? Do you just inject and then followed by a flush?
So I have to confess, we haven't used TPA, intraventricular TPA in our setup. I think 1 or 2 odd cases, and that was because the patient had obstructive hydrocephalus. That's the only reason why. So at that time, we did aspirate the CSF before instilling 3 or 5 ml of the drug. But the studies or the amount of literature that I went through, that protocol seems to be, so not, first of all, not all studies have explained their protocol or their methodology of how they are doing it. The studies that did, there were some which said that they aspirated 2 to 3 ml of CSF and then instilled the drug. And the rest, they just said that we instilled the drug followed by a 3 ml flush and locked it for anywhere between 1 to 3 hours. So again, there was no uniformity in how it was being done. But I would guess this would make sense, right? I mean, though they all mentioned that they measured ICP soon after the installation, and they kept the ICP monitoring on while the EVD was locked. So probably they did do that.
Our concern is always, the borderline cases where the ICP is borderline. You don't want to be instilling something without aspirating and then leaving it closed for 2 hours. That's the concern. That's why I wanted to check with you. The next thing is, we have this practice of doing daily CTs in these patients to see how the volume changes. Even if you see it draining quite well, on the CT, we would like to see hydrocephalus coming down or resolving, amount of blood in the ventricles coming down. Is that something that you read in the literature as well?
Yeah, in fact, that one thing struck me pretty hard because all of them did CT every 24 hours. And they use the DICOM software to actually measure the clot size subsequently.
Okay, the other things, so case selection you mentioned already, and the time to TPA, Dr. Shalini also asked, and I was going to ask about the neuro outcome timing as well. I also, just like Dr. Shalini, I share the same thought. I think we should give longer time before we assess the neurological outcome in these patients, because certainly the ones that we use TPA on, I mean, it's just anecdotal and a bunch of patients. Majority of them did very well, and majority of them have become independent. Maybe the case selection was good. Maybe we were lucky. I don't know. The next is, how long do you continue giving? Is it based on, you mentioned 3rd and 4th ventricular clearance? Is that the endpoint? Or, say, for example, after a couple of days, if the ventricles haven't cleared, would you still continue using it? Is there an endpoint? What is that endpoint?
Yeah, so Clear 3 actually mentions the endpoint very well. And these were the 3 or 4 criteria that they mentioned in that study. But the rest of them, they've mentioned so the duration ranged from anywhere between 2.5 days to 7 days. But majority of the studies said that clot resolution was seen within 2.5 days or 5 to 6 doses. That is what they have said. However, there is no clear mention of whether they actually stopped at 2.5 days and then continued just with the aspiration, of the blood tinged CSF, that's not been mentioned anywhere. So that is one point where I'm not sure what I should be answering.
Okay, thank you. I think that's all. Case selection, how long time to TPA Indian studies.
Deva, you muted yourself.
That's all I've dotted down here. Does anyone have any other questions or comments that they want to make? Any questions in the chat? No. In that case, shall we close this session? Dr. Urvi, Dr. Shalini, Dr. Prashant?
Dr. Urvi, fantastic presentation. Very, very important topic, very useful. And like Prashant said, we need to look in our population, what's happening, what could be done. Thank you for picking up these. Thank you.
Thank you, Dr.
We need
Deva.
this
Thank you, Dr.
opportunity.
Urvi. Thank you, Shalini.
Thank you.
And
Thanks,
thanks,
Dr.
everyone.
Urvi. Thanks for that wonderful presentation.